So the title of my case study is the ruptured Achilles tendon injury in a female collegiate basketball coach, a level 4 case study. Background: the patient is a 27-year-old female collegiate basketball coach for the women's basketball team at Middle Tennessee State University. The patient sustained a ruptured Achilles tendon in her right ankle on February 24th, 2021 during basketball practice. She suffered her ruptured Achilles tendon playing as part of the practice squad, performing the scout player duties for an Old Dominion University women's basketball player who the MTSU team was playing the following weekend. The patient was playing in a half-court offensive drill where she dribbled to the sideline, cut onto her right foot with a crossover dribble, and suffered the ruptured Achilles tendon. The patient immediately grabbed her right lower leg and fell to the ground. After a brief moment on the ground, the patient hobbled off the court under her own power and sat on the scorer's table for the remainder of practice. After a short moment of time, the certified athletic trainer and student athletic trainer conducted an evaluation of the injury, where the patient described severe pain, tenderness, inability to dorsiflex her foot, deformity in her calf, and swelling. The patient did not describe a popping sound or snapping sensation when the rupture occurred and was not noticed by fellow coaches or players. The patient was then placed on crutches and referred to the team orthopedic doctor at Tennessee Orthopedic Alliance. So here we obtained the practice footage from that day, and we'll go in sequential order, starting with 1 and ending in 7. So first, we see the coach beginning her crossover dribble onto her right hand and then back over to her right. As you can see in image 1, 2, and 3, the coach begins to plant on her right leg, going into image number 4, where that force into the court was provided. Into image 5, we'll see, as I circled here, the gastroc and gastroc looks normal. And we go into image 6, where the rupture occurred. You can see the deformity forming there as her gastroc looks very different and bigger. And this is actually where the rupture occurred. And going into image 7, as you see, she immediately hit the ground and was unable to continue. The differential diagnoses of this case study and injury was an Achilles tendon grade 1 to grade 2 strain, gastrocnemius strain, a soleus strain, posterior tibialis strain, a calcaneal fracture, and peroneal tendon injuries. Intervention: the initial evaluation of the patient, along with a positive Thompson's test and palpation, found the athlete to have suffered a full Achilles tendon rupture. The patient was then referred to the team orthopedic doctor at the Tennessee Orthopedic Alliance for evaluation, where the team doctor ordered an MRI of the patient's right lower leg. This MRI confirmed the ruptured Achilles tendon. The patient was placed in a walking boot and given oral medications to help with pain and swelling. Now, this continued for close to a week to 2 weeks before her surgery, which I will get into. The patient selected surgical intervention by the team orthopedic doctor at the Tennessee Orthopedic Alliance approximately 2 weeks from the injured date. So her injury date was February 24th. I believe her surgery date was March 10th, around there, March 9th. The patient was then allowed to remain coaching the women's basketball team at Middle Tennessee State University as long as she remained off of her injured right leg throughout the day. This was achieved by providing crutches to the patient and a chair during practice so that she cannot stand very, very long. The orthopedic surgeon at Tennessee Orthopedic Alliance elected for a traditional Achilles tendon repair, where a PARS jig was utilized and connected using anchors. The surgery was done with a percutaneous incision and was closed under the skin and covered with glue, while the jig was anchored into the calcaneus using those anchors as previously stated. Here we can see the post-surgical intervention here. As you can see, there's a incision underneath proximally to the calcaneus and was closed off using glue and closed under the skin so that the incisions would not be noticeable after proper healing. Treatment. The patient was placed in a walking boot and splint and was given a scooter for better mobility and resting position for the Achilles. At the 1 week checkup, the orthopedic surgeon removed the splint and we requested that the patient take 81 milligram baby aspirin as the patient was traveling to the CUSA tournament in Houston, Texas. This was done because the doctor did not want any blood clots or anything with circulation, any problem with circulation. And this baby aspirin would try to alleviate that stress of any circulatory problems as the patient was traveling on the plane. The patient has begun an accelerated rehabilitation program for non-operative treatment of Achilles tendon rupture given to her by the orthopedic surgeon. Now, going into her traveling, the plan was that the patient would conduct the first 2 weeks of her rehabilitation while she was in Houston and would utilize the athletic trainer for the women's basketball team and the weight room at the hotel so that she could begin her 2 week start to her rehabilitation. The uniqueness. This case is unique in that the patient is 27 years old, which is slightly younger than the average age of a person who suffers an Achilles tendon rupture. Achilles tendon ruptures occur most frequently in age groups of 40 to 49 in women. The patient also reported no previous injuries throughout her basketball career, which is unique in that she suffered this very serious injury 1 year after her time as an athlete, which is fairly quick in that she was a high-level basketball athlete and, again, did not have any previous injuries. She did not experience a snapping sensation or popping sound, which was confirmed by surrounding coaches and players and only reported her leg giving out. Now, a majority of the time, this popping or snapping sensation is heard either by the outside audience, which would be the coaches or players or parents, and was not felt by the athlete, and usually is felt by athletes. The patient is female, where Achilles tendon ruptures are up to 5 times more likely to occur in men than in women. So this provides a very statistical difference in that, again, this occurs mostly in men. Conclusions. Achilles tendon ruptures in individuals who are involved in sports teams, but not necessarily competing in the sport, are still prominent and severe in their pathology. And like previously stated, most injuries, Achilles tendon ruptures, occur later in the years, and I've heard of many coaches, especially in basketball, that have suffered this injury. Proper dynamic warm-up, conditioning, nutrition, cool down, and strength are important and needed by staff and practice players who are involved in the sport daily. Finally, deconditioning is vital and important in athletes who have concluded their athletic career but still want to perform or be involved in sport. Thank you. These are my sources.